Welcome everyone. I'm Glenn Sykes. I have been living with kidney cancer since December 2010. I became metastatic in June of 2015. So I've been at it for quite some time. I am wearing orange. Hopefully it looks like orange to all of you. This is March's Kidney Cancer Awareness Month, and orange, for whatever reason, orange is the is the color that represents kidney cancer awareness. So I'm wearing orange today. Encourage you to do the same maybe one day this month. About a year ago, I went to Judy Nicholson with an idea for an educational series that covered topics that I felt were not getting covered in other educational events that I went to that were research focused and treatment focused, which are of course extremely important, but wasn't the only thing of importance to me. So I grouped those topics under sort of a really broad heading, death positive topics. But I sort of struggled for a better description than that. And I recently came across a quote that I think does a better job of what I feel are the objectives for this series. So this is a quote. I'm not taking credit for it, except for quoting it. Is we're not actually talking about death here. We're talking about living one's life, given the reality of death. And I think that's a much more comfortable description of what this series is about. And this is the third installment of this series. I met with a small group of patients last spring about a vague idea of what this series could look like, what topics might be important to them, and I didn't want to just rely on what my view was for the important topics. And so they spent quite a bit of time with me, which I was really appreciative of, and I'm hoping some of them are on here tonight. And came up with what I consider sort of a series outline, different topics of importance. And this is educational focus. It's primarily meant, rather than sort of providing individual support that we might get in a support group, for example. But for me, and I think the audience I was speaking to at that time, education that informs is a great way to feel supported in our journey with cancer, whether we're a patient or caregiver. So I hope that everyone here on the call today has that in common with me. I mentioned we had our first webinar on palliative care with a palliative care doctor. That was sort of the second installment last summer. I'm really sorry it took me a long time to come up with series 3 in this. That discussion was really lively and enlightening about palliative care services, which is something that can be really misunderstood. And I hope that audience enjoyed that. And again, I hope they're joining here tonight. I think tonight's session, which has 3 experts who deal with patients that have exhausted all reasonable treatment options, promises to be even livelier. So I hope you've come prepared with some questions and thoughts to learn. Before I introduce our panelists, I want to express my gratitude to Judy Nicholson and particularly Linda Anderson from that organization, who was willing to take a leap of faith that what I was talking about had an interest to an audience of patients and caregivers. I had been really shopping that idea around for longer than that, and I didn't get a lot of takers that this was an interesting topic. So I really appreciate Judy Nicholson saying, yeah, let's give it a try and see. So thank you, Linda, and the Judy Nicholson Kidney Cancer Foundation. So let's get into it. We have 3 great panelists tonight that interact with patients on different needs. I don't know how they appear on your screen. I always feel like my screen may look different than your screen. So I'm just going to introduce them in alphabetical order and ask them to raise their hand so that you have a name and a face for that. So Danica, right there. Danica Arizola is an end-of-life doula, an integrative medicine practitioner. I've known her the longest of our panelists for quite a few years because one of the things she does is provide massage and Reiki care to patients in the infusion center at Penn Medicine, where I get my care. So Danica and I have spent a lot of time while I've been in the infusion chair and taking really good care of me. And boy, our topics go all over the place. And it's really been and as much as one could say, I enjoy going to the infusion center, she's a really bright spot in that time. So thanks, Dana. Thanks for joining us. Marge Bowen thanks, Marge, raising your hand, has many years. We were talking when we first met, just so many years of experience, of nursing experience in the medical field. And currently, she serves as the liaison to patients seeking hospice care, also at Penn Medicine in Philadelphia. And finally, Katerina Mako heads up spiritual care at the chaplain's office at Penn Medicine. And I never saw the org chart, but I have this image of it being a pretty far-reaching organization at Penn Medicine. And I never really expected her to say yes to this invitation. So when I presented it, she said, gee, I'd like to do that. So I was really pleased that she said yes. So thanks, Katerina. Thanks for being here. All right. So let's, to get things started, what I've done is think about a list of questions that I've shared with our panelists ahead of time. And I had that list prepared just to sort of like prime the pump for your participation. So I hope that you came with some questions or some thoughts to share. They don't always have to be questions. You can just share a thought. I'm going to start to say a few questions now, turn to each of our panelists and ask them to respond. And then I'll move through, I'll probably ask about, see how things are going, 4 or 5 questions, and then I'll pause and take your questions. If you prefer to put your questions in the chat box, Linda Anderson from Judy Nicholson is paying attention to the chat box, so we'll make sure we take them there. Or if you just want to come out and ask them when I pause, that would be great. So I just introduced you, and I'm not sure that that introduction probably did you service in terms of all the things that you're probably involved with. And as I said, education is a part of what this is, the primary part of what this series is about. So I'm hoping that you can educate our audiences about what you do by talking to us about when you work with patients that are facing end-stage disease, they've exhausted their treatment, reasonable treatment options. What kind of matters do you help them with? And I'm going to turn to Danica first. I'll probably mix up the order, but this time I'll just go in alphabetical order. Danica, can you start us off? You're on mute. Thank you.
Sure. Yep. There we go. I made some notes, so if it looks like I'm reading from my cards, I apologize, but I wanted to be prepared. So it's interesting. End-of-life doula work is fairly new, and there's no licensure, kind of a legislative overseeing. So the work that is offered is very individual per doula, I would say. And for me specifically, I started this work through body work because that's what I do. And then it sort of led me down this path. So most important, I am part of what I would consider palliative and hospice care. I think my services are helpful in both of those areas. And my main task is providing emotional and spiritual support via deep listening and personalized, non-judgmental and non-medical care, and also soothing comfort measures. I like to think of myself as an ally for the person who is dying and for also their caregivers and families. I align myself with the goals and wishes and needs of each client. So whatever it is they're needing, I try to fill in the gaps of all the support they're already getting. My experience so far has been a lot of companionship It most often always includes body work because that's just what I do. And I think it's a strength. And it's also needed at the time of someone's going through a difficult disease and end of life. So I also try to normalize and find and to recognize beauty in the expression of being human, and also to bear witness to the work of of the dying process, because it is, in my opinion, is a sacred thing. So it's, companioning rather than treating, serving rather than fixing. And it also includes empowering, encouraging loved ones of the person who's actively dying, to operate within their comfort zone. And again, so that I can support them and the client wherever there's missing gaps. Sometimes that's running errands. Sometimes it's making meals. It's been a vast variety of things.
Right.
Yep.
Thanks. Pretty broad job.
I know. And like I said, it's individualized. So far, It's individualized per person.
Right. I remember when we spoke, you said kind of companionship, just being there was really, you felt a really articulated need for other people, your patients, just to be there with them, which was
absolutely. And I think a neutral, like a person that doesn't have an opinion here or there. I'm just there to support the person however they are in that moment. I'm not trying to make them think about a certain decision that needs to be made, or I'm just being present with them where they are.
Thanks.
And trying to provide comfort. Yeah.
Yeah, I picked up, you said non-judgmental, which was great. All right, Marge, it is your turn to tell us, what do you work with patients when they're facing end-stage disease? And in particular, Marge, could you also, although we did have a session on palliative care, I think in a lot of people's minds, palliative care, hospice care is sort of like a mashed potato sometimes. So if you could help distinguish that as well. Thank you.
Sure. So I'm a nurse at Penn for 25 years, and sort of in the last 10, I've been mostly hospice liaison and doing some other things, but learning about the entire hospice process at Penn. So I would say just a quick, difference between palliative and hospice is really palliative is an appropriate kind of earlier comfort focus. It's a curative kind of therapeutic way. They're looking at things. Usually the patient is in the hospital or in the home. It comes with traditional billing through patients' regular insurance. And usually it's a consult service, which helps patients decide what treatments they might want to continue or not, moving forward in their transition. Then hospice is it's sort of the comfort measures only. When you choose that, you've met all of the essentials for the hospital and for your doctor, your oncologist, whoever it may be. And you suddenly realize that really the things that are important to you are to be generally home, to forego any active treatments. Really, I know the criteria legally is you have 6 months or less to live, and that's generally speaking if you had no treatment at all and the disease took its course, and it actually depends on which hospice you're with, how those treatments go, which we can talk about later. But so that's really the difference. I think most of our patients, they can receive hospice in the home. They can receive it in the hospital. That's really a shorter stay when you're closer to end of life. And we also provide hospice services in facilities, long-term care, inpatient hospice units, residential hospice units, and that's, kind of our big thing. Medicare is a particular hospice benefit, which a lot of the other insurers, commercial and others, also provide. So hospice benefits are generally covered as a bulk thing. So kind of the differences are about payments and about what you can do and what you can't, and criteria based on insurance. And what I do at Penn really, in general, is I get a referral from doctors and others, social workers, discharge planners, lots of folks. I could even get them from nurses, but nurses are always a little hesitant. But then we go visit the patient in the hospital, all Penn hospitals, by the way, and find the patient family, talk to them, find out where they want to be, what their plan is, what they're thinking, and help them to get where they need to be in any of those places that I mentioned. And we kind of set them up with a good plan that will be a safe discharge. And if they want to stay in the hospital, a safe journey there. So that's kind of the big overview.
Marge, can I just ask you maybe just an example or two, like what's in this plan? I know it fits under hospice care, but what's an example of something that would be on a plan, or example or two of something that would be on a plan?
I think primarily it's first and foremost is going in and listening to the patient and family and find out what's their plan. Kind of where are you at in your thinking, and where do you think you are in this transition? And then if they want to go home, which I would say is the biggest chunk of people I see, they kind of are in a place where, for many reasons, folks want to go home and just be with their family and be comfortable and out of pain and, other things that are going on. So what we do is provide that plan. We make sure that they go home with the medicines they need. Our pharmacy then takes over and they just send things to the house. So there's no back and forth to CVS and all of those things. We try to just make it as comfortable as possible at home and provide them everything they need there. I will say, the first thing I always say to everyone when I walk in a room is hospice is not 24/7. I know a lot of people have that kind of thing that hospice moves in. We really don't, and we can't, but we do provide nursing, a nurse who provides the care and the oversight. They're generally there 2 or 3 times a week, more as you need them, moving forward. And we provide home health aid services in the home if they need it. We provide social workers. We work as a team. We provide chaplains. Our chaplains are mostly all non-denominational, but they're there to provide lots of support and things like Danica was saying, which I appreciate Danica's work for sure. So in the home, it looks a little different. We provide equipment that's covered by the hospice benefits. So we like to get that in the home, get it set up already so the patient gets home and right where they need to be and have everything they need. So it's a lot of coordinating those kinds of things, but primarily just initially finding out what the patient's thinking, where they want to be, and does the family agree? Sometimes
right.
That's also one of those things to negotiate.
Right. Yeah. So it must provide a lot of help. I mean, what you're doing sounds like it provides things that might be on the plate of a family member or caregiver, and you're taking that off their plate or giving them the opportunity to take off there, which is helpful. You mentioned, I just want to come back to something you said about 6 months, because what I've heard, correct me if I'm wrong, that 6 months isn't firm.
No, that's just the general. Yeah, that's just the general insurance kind of piece of it. Gives it a frame, and when you initially sign on to hospice, your doctor and one of our medical directors for hospice have to say yes to that 6 month or less kind of piece. And if they all agree that everybody meets criteria, then we go from there. But we have patients at home for a couple of years. I mean,
right.
On service, and they can remain on service. Yes.
Thank you.
Yeah.
All right, Katerina, you're up. So if you can talk about, in your role in the chaplain's office, what kinds of things do you help, what kinds of things the people you interact with, patients, caregivers, what they're facing, and what kind of help and assistance that you provide?
Thank you, Glenn. I'm really honored to be here, and thank you everyone for allowing me into this space and spend this time with you. So I've been a chaplain for over 25 years, and everyone thinks they know what a chaplain is, but really what a chaplain is someone who provides spiritual support, and in however the person needs that, right? Chaplains are trained and are theologically trained and understand the different traditions that people come with, but really it becomes very, very specific, very individual. The overarching work that spiritual care providers do with people who are, running out of treatment options is really looking at themes like meaning and purpose in life. That's very, very personal, but pretty consistent. One of the other things that spiritual care providers do that's really equally important is help people sort out their thoughts and feelings around their religious tradition or their philosophical beliefs or their views on life. When in those times when treatment no longer works, really challenges someone to think deeply about themselves, and it has a way of clearing out beliefs and that are not true about oneself, right? So those kind of existential crises do clean the house in a way, and spiritual care providers are there to help guide that, because that's a very disorienting and scary time, especially when people have negative religious ideation around their lives, right? That could be terrifying. Not only are you facing the end of your life, but then your next life is threatens to be awful, right? So we do a lot around, and that's where theological training comes in for chaplains, to help with that, help sort that out, and help correct a lot of negative religiosity. Okay, it's a very special time in people's lives, and a very fruitful time to address one's inner life, right? So, I love what Danica said about companionship. When there are a couple of studies on spiritual pain, and that this sort of the primary spiritual pain of people in these circumstances is a sense of abandonment and being alone. It scares everybody around us when to watch somebody experience this in-betweenness, right? The interesting thing is, and what I like to always bring to the conversation, is that if we're really thoughtful about our lives, we are all living in that in-between, because truth is, none of us know when when it can all end in a moment's notice. So it's important to be aware of the death anxiety, and then use that anxiety to learn deeper truths about ourselves. I hope that answers some of the questions.
It does. And do you meet with patients face to face? Is it on the phone? And I can imagine these discussions could take a long time. And do you meet with them multiple times, or how does that work?
Oh, absolutely. So we take referrals. We cover all of HUP, and we also go over to a Perlman Center for the outpatient when requested.
Right.
But we take referrals from doctors, nurses, social workers, and the patients themselves. We we do meet in person if the person is impatient. And when a chaplain is requested to go, the person is ready to talk about deeper things, right? And and sometimes, Glenn, there's no formula. Sometimes someone, and it might be at 2:00 in the morning, right? We do have chaplains 24/7 on site at Hub, and when a person's ready to talk about things that they might have never talked about before, considering when they're looking deeply at their lives and sort of facing the possibility of not being alive anymore, right?
Right.
It sometimes that one conversation changes the trajectory of that person's thinking, and they then engage other resources in their lives, right? And sometimes we're called back every day, and maybe sometimes twice a day, because some people are extremely anxious, and even though they're not ready to hear, right? So it's this gentle companioning as one tries to help someone kind of comprehend what's really happening, right? We've done Zoom meetings with people, and that's just not just our staff. I mean, our patients, but our staff as well. Chaplains are available for staff as well, because again, watching someone struggle with their health this way has a profound effect. I always think of it as a rippling effect throughout the people who surround them, throughout and their families and society. So to answer your question, it could be we meet once and never again, or we meet multiple times, as much as is needed. And we take, so it's not, let's say I'm called to a patient's room, they're on my floor, on my unit, I go. And it could be that I discover that Chaplain David will probably be more in tune with this person culturally and for many different different ways. So I would refer and engage another chaplain, right? Because a different perspective might help that patient. So we do work very much as a team and a team together with social work and the nurses and so on. So I don't want to forget to say that in some way, everyone offers spiritual care. When you go in with love in your heart to encounter someone, that is caring for the human spirit, right? So we don't, chaplains don't have a monopoly on that, hardly. But it's but we do specialize in sort of like the deeper, tougher stuff,
Right. That's a good message. I think you gave that to me one of the first early discussions. I think it's a great message that we all provide spiritual care to each other, probably to ourselves. So thank you. And while these three individuals are affiliated with Penn Medicine, and I know the patients and caregivers on here probably have care at many institutions, my guess, correct me if I'm wrong, is that any kind of national cancer center or academic, teaching hospital is going to have similar type resources available. So I don't think anything that we're saying today would apply to other people at other institutions. So thank you. All right. So you're sitting in front of a group of patients and caregivers who probably thought about this time, maybe a time when no reasonable treatment options exist. I know, for example, in my patient community, unfortunately, we are faced all the time with members of our community, sometimes new members, sometimes longstanding members that are struggling and eventually pass. So what are the important messages that, based on your experience with that population, what are the important messages that you would like to convey to this audience? So I'm going to start with you, Marge.
Thanks. So I do think it's one of the best things to do when I walk in a room. First of all, I never say that I'm from hospice because the word frightens people, and kind of families, and stops the conversation pretty much right there. So generally, I'll just, ask where we're at. What do we know about the disease process we're in? And what have the doctors said? What are your questions? And listen. I mean, the biggest thing for me is to listen to what's going on for the patient and the family and kind of help with, those questions they might have. I also share that it's their journey, and try and find out what's important to them. Lots of people like want to go home for different reasons. I want to be with my dog. I hear that a lot. And want to be with my child, want to be with my family, different things. So I think really listening and kind of hearing what they would like their next transition journey to be, and then offering some, helpful hints about what we can do to help them get there and make that journey successful. But I think it's always important to hear what it's important to them.
Right. Marge, I'm looking at my question list, and I'm going to combine question 3 with this as well, because I think it's related, which is, are the things that, if that moment that you described is a long way off for us, are the things that you think we should be doing now, some thinking we should be doing, some conversations that we should be having that may bring, I hate to use this word, but like efficiency to that process.
No, I totally understand. And I always think that there's never a good time, bad time, right time. It can be just how it comes to be one Sunday during dinner. You're all around and somebody mentioned something that brings it up, and you just ask some questions, like, what would you like your last few days of life to look like or be like? Or there's some things that our social workers use called 5 wishes, which is it's a really wonderful document because it kind of goes through a few pages and different questions. Like you could just make it kind of a fun thing. I know it's not a fun thing, but like, so what kind of music do you like? What would you like your service, if you want one, to be like? I know for me, I always remember my grandmother saying to me, if you do a viewing, I'm coming back and haunting you forever, because I do not want people to be walking by looking at me when I'm dead, So I totally clearly understood that, and we managed to, support her wishes. So I'm always about, there's never, it can be any time, but I do think it's good to plan, because being in a really, particularly if you go to the hospital for some emergent kind of thing and nobody in your family is aware of your wishes and you haven't had those conversations, it's just really tough for them to go in and try and ask the family, what do you think, this person might have wanted. So planning tools, there's lots of them on the internet, things like those 5 wish things, but it's really a good thing to do, even just over dinner, anytime.
Right. Thank you. Yeah. My mother, who is 100.5, has a little bit of a control freak, has a very specific list of all the things that we are to do or not do. More importantly, actually more like not to do. I'm reminded when you talked about your grandmother.
Yes.
And it occurred to me as you're talking that she prepared that list a while ago. But here she is, over 100 years old, that it's probably a good idea to review those things.
There you go.
So she probably has more things she doesn't want us to do more than change
the
her
list
mind.
Is probably longer now. Yes.
Right. Okay. Katerina, so, what are the important messages based on the work you've done with patients and family members, caregivers? What are the important messages you would want to convey to this audience of patients and caregivers And then again, is there anything that you think we could be doing now when that moment may be a long way off, and hopefully for all of us? Thank you.
Thank you, Glenn. You know what I would say, it's never too soon to start working on your inner life, right? And so that's what I would say now. I mean, by now you've been through a lot. A lot of you have been through a lot, and you know, the stresses and the disappointments and just the hard work of getting this kind of intensive health care, I'm sure, you know, has worn on you.
Yeah.
What I would say is to start really embracing your inner life and cultivating that. And that's, you know, it's cheap because it doesn't cost anything. And it's not easy though, because cultivating the inner life means that we sort of shed our the many layers of veneers that we build up simply to be in society, and to become more authentic with ourselves and with those around us. And you know, that's a beautiful process, because it affects the person who's practicing it, but it has a profound effect on everyone around you as well, right? So I would say this is a good time. Any time is a good time, and it could be as simple as sitting with your thoughts for a few minutes. You know, there's also much about mindfulness and meditation and so on, and it's all there. Unfortunately, most of it is been so monetized and commercialized, and it I feel, in my opinion, it takes away from its essence. It's, you know, the spirit is all around us and in us and in everything. All if we just take a minute and connect with ourselves and accept ourselves in whatever condition we find it. And of course, it's ebbs and flows. And it's
Right.
a way of learning to accept those ebbs and flows and loving ourselves through all of that. That's what I would. That's the message I would want everyone here to know, that your suffering, it has dignity. You have already suffered so much, and to harness that the power of that suffering to grow inside yourself. You know, to grow your spirit. If you have a belief that engages a higher power, that's a good time to have some serious conversations with that higher power, right?
Right.
And then listen. Yeah.
Thanks, Katerina. Thanks for acknowledging something that I think sometimes gets lost. It's exhausting being a cancer patient.
Yes.
And you know, I've been at it a long time, and you sort of get used to it. But it is exhausting just to keep up with everything. And I think what I understand your point to be is, in spite of that exhausting effort to be a cancer patient, it's equally important to take time for, as you said, cultivating your inner life, and to find a little bit of energy to that, because it's easy to just say, you know, my life and all my energy is absorbed with just being a patient, keeping up with doctors and treatments and how I'm feeling, and thanks for that important message. I think that's great. Thank you. And Danica, you're going to bring us home on this question. So again, one of the important messages from your work with patients and caregivers that you could like to impart on this group, and is there anything that we could be doing right now when we may be at a, you know, that may be a far off point in the future? Thanks, Danica.
Yeah, I think Marge and Katerina said it. There's a few things I'll add. There's a quote, a Ram Dass quote, the way that we regard death is critical to the way we experience life. So I think that's kind of piggybacking on what Katerina said. So when your fear of death changes, the way you live your life changes. What came to mind with your first question was just question 2 was my immediate thought was like, fear not, worry not. because I think that's immediately where people go, and for good reason. So, and then exactly what both of them said is like, so how do we help lessen the fear or face the fear even, is, there's a book, A Beginner's Guide to the End. And the first chapter is on don't leave a mess. And it's all the logisticals, like all the paperwork, all the things. But then there's also, it's like cleaning out your logistical attic, but then it's also your emotional stuff. Like, to me, what I think of is what is going to bring this person the most peace, the most ease, and to have as little regret. So how can I help assist in that? So sometimes that's helping with estranged relationships. Not that I'm helping, but get them the help they need to, say sorry or forgive or I love you or whatever that is. I think it's kind of saying in different words what Katerina was saying is like looking at your inner life and then attending to those logistical, legal type of things, because that's important as well. And then I think there's a peace of mind that comes when you've handled those things. For instance, like my mom, and this was when she first told me about this, I was taken aback because I instantly thought, like, does she know something that like we don't know? Is she, because she's been sick for a long time. She's had 2 kidney transplants. And this was maybe 10, 11 years ago. She just called, we did like a whole FaceTime with our immediate family, my sister, my dad, and her. And she's like, I've already paid for my funeral. I've already got all of these things done. I've got the plot, all the things. And she's like, I don't want anyone having to deal with anything. And at the time I was like, so like, it made me sad, obviously, to have to think about that. But now I'm so relieved because I know. I know exactly what she wants. I know like there's nothing, because also I think there's a fear for the people, families and caregivers left behind, of doing something wrong. So it's a relief to sort of have everything planned out so we know exactly what to do, like what Marge was saying. Yeah, I hope that summarizes everything.
And thanks for bringing up that we're not, this is not a commercial enterprise, but I really do appreciate you plugging A Beginner's Guide to the End. It's yes. By a gentleman named B.J. Miller, who had a really tragic thing happen to him at a really young age, and is I guess a palliative care doctor now, or hospice care doctor, and he had a co-author, Shoshana Berger. I love that book, and I haven't finished it, and I've had it in my bookshelf for a long time. But one of the things I love about that book is, I think, what you just hinted at. There are chapters of things you could do now, and then there are chapters like, you know what, I'm going to worry about that.
That's for later, yeah.
and it wasn't a book like you're going to sit down and read it all, but you read a chapter, and it's really the style of it's great, and really practical things and less practical things, more spiritual things than practical, but it's a really good book. Again, A Beginner's Guide to the End, and B.J. Miller and Shoshana Berger are the co-authors of that. You may have, B.J. Miller is often out on the speaker circuit. He's really interesting, good speaker. So
I love all of his talks.
Yeah. All right. So I recently read an article entitled A Better Way to Die. And there was a quote in that I just want to get your reaction to. It doesn't have to be, it can be a quick reaction, but I liked it. It said, death doesn't have to be awful. And I thought that was a good thing to hear, because there's a lot wrapped into the awfulness of death in society and our culture. So when you hear those words, and what does it mean to you? What thoughts come to mind when you would hear death doesn't have to be awful? And I'm gonna start with you, Katarina.
Well, I have mixed feelings about that. Because it presumes that death is awful. Death is part of life. It is. What's awful when we have an inordinate attachment to it, right? And I think in this youth obsessed society, there's just no way to dress it up in that way, right? I've never seen anyone post anything on Facebook that said, "Hey, I had the best funeral." You don't know who was there. And I don't mean to make light of it. I think what society is coming to is maybe a deeper appreciation for that process in life, because death is a process. So I'm glad to hear that people are thinking about it, but I also feel that death needs to be respected. So it's more than not being awful. We need to work towards respecting that process, and that we're all in. And it's particularly intimate to me because I just turned 60. So like, oh my, a new decade. How did this happen? Who's that? Um, and I'm reading a book right now, Staring into the Sun by Irvin Yalom, and it's all dealing with, and he's a well-known psychologist. It's dealing with death anxiety, and it's interesting. I didn't know I had death anxiety, but it was, was coming up in strange ways, like worrying about my age, like, wondering, just normal stuff. And so I'm getting off topic, but I like I said, that doesn't have to be awful. It just sounds like the beginning of a bad commercial. I'm sorry, that's the honest truth.
And Karen, can I ask you, because I'd like Linda to put in the chat, can you just repeat the name of that book?
Oh, sure.
You have the cover right there.
I can put it into the chat if you like.
Oh, that's great. Thank you.
Show you what it looks like. So it's Staring into the Sun, Overcoming the Terror of Death, by Irvin Yalom. And I'll put it in chat. It's yeah, he's a prolific writer, and he breaks down the complicated things in very I don't know, easily to digestible things.
Hey, thanks for that tip. All right, Danica, death doesn't have to be awful was the quote that I read. It resonated with me, or just sort of like broadened my perspective, because you hear a lot of awful. What does it mean for you? What is your reaction to that?
I think most people think of that it's awful because I think not always, but oftentimes it takes people by surprise. Even though it is the one thing that we all will do, it's the one thing we share in common, all living things, but we forget because we're not mindful, or we're not really thinking about it, unless you have someone like you yourself, or someone is in a position where they need to start thinking about it. I don't think death has to be awful. I've seen some awful dying. I believe that it is a sacred part of living. I think it can be beautiful with ritual and ceremony. I think I think the more that we can trying to articulate what I'm saying, because I think it's really more challenging for the people that are left behind.
Right.
It's awful for them. So if there can be some support along the way for us, like acceptance, there's those it's the stages of death, like the denial, grief,
Right.
your bargaining, all those things. Like I think if we can catch people, if there can be support for not only the person that's dying, but their family, caregivers, and get them in the stages so that there can be a level of acceptance that this is normal. This is it doesn't have to be. I mean, my personal belief is that our souls are eternal. And I actually when I was doing the death doula certification, it didn't even occur to me that I was actually very afraid of dying. And I think what helped me, I study a bunch of different spiritual practices. I mean, I have a lot of different spiritual practices, but one thing that helped me is if my soul is eternal, then my body is just this. My body may pass away, but my soul is eternal. And I don't know if no one needs to believe that, but for me, it's a belief that helps me come to less fear and more acceptance.
Right.
And I'm not saying that's going to carry me through to the absolute end, but for right now, it's helpful.
Thanks. And I didn't deliver that quote for anyone to say, "Oh, death isn't awful." And it sounds to me, in your view, it doesn't need to be. But
I think
you have seen some awful aspects of death, and I think so. There's room for both, I guess. Maybe.
Yeah, no, but I think if we can all, and I think what everyone here on that panel is trying to do is to make the act of dying and the dying process as not awful as possible.
Thanks.
Because so I think the more understanding and the more normalized it is, and what you're doing is so wonderful for people to actually have conversations around it, to realize that it doesn't have to be.
Right.
So,
thanks.
Yeah.
Marge.
Yeah, so it's interesting because I also worked on our inpatient hospice unit, which was located down at our Rittenhouse facility, but closed recently, and very sad, but had lots of experiences there with folks who were in both situations. Some of them thought it was awful, and no matter what you could do medically or clinically, it wasn't helping. It was more existential grief. And so it was good to have chaplains and other folks like Danica around us so that we could help in that realm. But I also experienced a person who was like amazing to me. She came in very prepared and was not going to make it awful. She decided that on a certain date, she was stopping the 102 people she had on her email list. So she wrote everybody an email and told them that she was done with the emailing stuff. She was going to stop this today, and that she was getting close to the end of her life, and a whole dissertation which she sent out to everyone, which was great. And she did. She literally passed away like 2 days later, and in a very kind of way that she wanted. She ate the last thing that she wanted to eat. It was very structured. It was just who she was, so she had planned it right down to that last moment. It was fairly incredible to see. But yeah, I think it's true. I think it really depends on the time, the place. I mean, sometimes it's not your choice, so it can be awful. Trauma is always difficult situation to be in, in the EDs and stuff. But yeah, I don't think it's always awful. It just really does depend on where, when, and how it works for you specifically.
All right, I'm going to ask one more question from my list. I do have other questions, but that's your signal to the audience to start thinking about your questions and things that you want to tell us what's on your mind. So, turn to you. I'm sorry to describe what I'm about to ask as regrets, but I couldn't really come up with another word. And I think someone in one of their answers earlier talked about regrets. But based on what you have witnessed, patients and caregivers and family members experience, that may fall under the category of regrets or regret-like or something like that. What would you want to caution our audience about when they're facing end-stage disease, to maybe avoid that, to not have, we'll say, any regrets or that regret or something like that. Some words of wisdom from that. And Danica, I'm going to start with you. I think I got all out of discombobulated with the order, but Danica, I'm going to start with you.
For this one, I would say just say all the things to all the people that you want to say them to. It's I think the ego gets in the way of us being proud, but I think as it gets closer, yeah, I think the thing I hear most in terms of regret is the not making, what's the right word?
Amends?
Amends. Yeah, like amends with important people that may have become estranged, or maybe you never said, I'm proud of you, or I just think all the unsaid things, just feel, I hope that people feel free to say them. And
say them early and often.
Yeah, early and often. Like okay. love on all the loves that you have, and then free yourself, free your heart of anything that's weighting it down. Try to just go in as lightly as possible, if that makes sense.
It does. Thank you. That's a good message.
Yeah.
Katerina.
The saddest thing is when we find someone who didn't, who couldn't find their way around doing that, right? To make peace. Family divisions, right? Like old feuds, I mean, we're talking like set in stone feuds for 35 years, 40 years. That is the pain of regret that we encounter. I encounter. I can speak for myself. That is very, very painful, and often family dynamics, existing family dynamics make it difficult for someone to tell someone they love them because somebody doesn't want them to do that, right? Like there's these camps that have been solidified, and we have helped people call people, waited till the family was gone, and then they reached out. And it's a beautiful thing when, let's say, we track somebody down, like there's no contact information. I think we find them. The joy and the relief and the peace is nothing short of miraculous. And it's really important to confront unhealthy family dynamics, because really for the person who's getting ready to go check out, yeah, it's done. And everybody has to deal with their own feelings. That's what we encourage patients to do, or people to do, is to say, you are in complete control here, and you're about to check out. What do you want? Nobody can tell you how to die.
Right. I bet, I don't want to put words in your mouth, but I bet you have seen the longest simmering family feuds melt away really easily at those moments, and regret that couldn't have been done years before. Right?
And and healing can really take, I mean, in a nanosecond, a lifetime of pain can be healed. That's that's just take that as at face value. That is a fact. And then it is interesting. I've not heard people say, "Oh, like the other regret was like, oh, why I didn't do this sooner." It's almost like that release of all that energy is so great that it just does away with everything else. And it doesn't matter in the moment. I think people who are getting near the end of life are very much in the moment. Like that moment is it. The universe is encapsulated in that moment. And as and speaking of current practices for you, practicing being in the moment will also help you be very much in the moment and determine your life as long as you have it.
Thanks. Great message. Marge, do you want to add anything to that? What patients you've met through hospice or in your nursing career that regrets that they've had that maybe we should think about doing something now before we get there?
I think it's the early and often piece is absolutely the piece for me. Because we experience it a lot. We nurses are with the patients the biggest part of the day. When you work 12 hours, the doctor might see them for 5 minutes in the morning, and then we see them for the rest of the day. And so on both experience levels, we've seen a lot of folks that have a lot of regrets, particularly toward the end of life. And, it's good to talk about it. I think our chaplains and social workers are great in that piece. But in the last moment, it's sort of like, give it up. It's we're done with that now. That's a piece that, didn't happen and probably won't. And let's move on and do what you want to do from this moment. Hard to do sometimes, but and as Katerina said, we also find people, it's just incredible, they're like estranged from somebody in their family for a long time, and we actually track them down 1 minute on the telephone and it's all gone, it's done. It's like, could have done that 10 years ago. It would have been a good time, but at least it's done.
Right. Thank you.
Yeah.
All right. Here's how we're going to handle questions. Well, if you want to add a question in the chat box, and I'll check back with Linda in a second to see if she has any, that's fine. If you want to use if you know how to use the raise your hand feature in Zoom, you can use that. And if you don't know how to use it or too tired to point at that box in Zoom, you can just shout it out. We'll try to keep some order here. So what questions do you have? What's on your mind? And Linda, does anyone have anything in the chat box?
No, not yet.
All right, thank you.
Sure.
I can keep asking my questions, but I'm hoping that you have some things that you want to find out. Tell us what's on your mind. It doesn't have to be a question. You can just tell us what's on your mind or how you reacted to this. And Linda K, thanks.
Okay, can you hear me?
We can.
All
Thank you.
right, yay, the mute came off. Okay, I just want to say, you guys are talking about regrets in that. And for me, I've regretted not cutting certain people out of my life for too long because of how much they hurt me. And so upon this diagnosis, I have cut them out of my life. And I feel so much better. So I just wanted to throw that in there about regrets, right?
It's another side, and I appreciate that. That's what we wanted to find out. Right?
Yeah, okay. But the thing I wanted to ask, everybody in the group, you guys, I have been experiencing, I don't know if I call them flashbacks, but memories that are taking me back to times in my life that were so painful. And so then it's like I'm reliving them again. And it's like when you had events that were so painful that you had to change who you are, right? How society views you, and you learned from it, but it's really painful. So is that like just aging, or is it because I'm facing death? I just wondered that, you know?
So if I could just maybe recap it to make sure that I have it down, and I'll give our panelists a moment to think about their response, is you find yourself being reflective about things that have happened to you in your past, and you're wondering if that reflective process is because you have a cancer diagnosis, or it's just because you're getting old, or something else going on. And so did one of our panelists want to take a stab at starting at an answer for that question, if you have an answer? Marge, you're on.
So I just wanted to say that, so life review like happens almost every day for me at the moment, because I'm not a tot anymore. I don't think it's just about being my age. However, I think it is also about the people I meet and their reflections and life reviews. I hear a lot of them, and I hear your kind of story quite a bit. You know, it's generally goes one way or the other. They are reviewing a lot of really good things, or the bad things come up, you know. And I think it's not unlike what Katerina said earlier about cleaning your house, you know. They may come up as flashbacks, but maybe it's also your mind just like freeing them, you know, let them go, and we're done with that. And now that you say you've, you know, managed to move some folks out that were not good for you, and you're feeling better about that, stay on that road.
Yeah, because I was feeling like, you know, with the flashbacks, it's just making me more aware of why I am who I am. You know, like the events that happened that changed me. And then I go, oh, that's why. Why didn't I realize that as I was going through life? You know,
Yeah,
like,
because you were young and didn't get it, but it's really good to
yeah,
reflect on it now and go, look, I'm not doing that going forward, you know. So
yes,
the
yes,
learning
thank
piece.
you. That's very good.
Yeah, and you know, just sharing my experience of my diagnosis, you know, it's a pretty traumatic event to hear someone say you have cancer. You know, and adds to the trauma when you say someone says, and now it's grown and spread. And those are reflective moments. I think that I have learned about I think I learned about myself. I was 51 when I was diagnosed. I think I became a much more thoughtful, reflective person as a result of that, maybe at an earlier age than I would have. Why I would never, I've heard, and some of you may have heard this, people say, well, you know, that was sort of a gift to my cancer diagnosis. And I would say, man, not a gift. You know, I don't want a gift of a cancer diagnosis for anybody. But in a sense, that was a positive that came out of it. I think I became a much more reflective person as a result of getting that diagnosis than, you know, who I am and who my relationships are, and what kind of person I am, how am I facing this disease, than I would have if nothing that hadn't happened when I was 51. Katerina or Danica, do you want to add anything to what Linda's reflection was, or a question about her reflections?
Linda, I think what you're going through is very, very normal, and it is part of that sort of life review. And I'm hearing you say that you're recognizing the difficulty of your journey, right? And that's what it sounds like to me. Like it was extremely painful, and this is what made me.
Yeah.
I mean, that's it's almost a badge of honor, right? That you have come to this point,
Yeah.
in spite of the adversity.
Yeah, because before, I think, you know, part of coping with some of the stuff is that you block it out somewhat, or I heard someone on TV talk about it. I was like, that's it, is that you summarize an event in your head to where it's just this little blip. But what I'm doing is it's like this big thing, and I'm feeling all the emotions. So I don't know.
Yeah. Well, Henry Nouwen, this theologian, Henry Nouwen has a beautiful reflection that says when our hearts are broken by pain, it's really breaking up the hard soil and allowing the softness to emerge where things can grow. So,
Hmm.
I've always found that to be helpful, like because it is it's heartache when we truly process a difficult situation. But to think in terms of well, yes, my heart is breaking, but it's breaking open, right?
Wise words. Thank you. Does someone else want to have a question, ask a question, or tell us what's on your mind? Or I'll go to my question list, but whatever. Anyone? Shy? Okay. Well, I'll go to my questions and then I'll check back with you all and maybe something else will come up. So this is a more practical question, but when you're carrying out your responsibilities in what you do, how do you interact with the patient's primary medical team? For example, the oncologist, the person we probably see the most often, most frequently throughout, living with cancer. And I'm assuming that you do, but maybe that we should just start with say, how do you interact with the people in the patient's primary or care team? So, Marge, you want to start with that?
Sure. Actually, I interact with the doctor teams every day. So, and the primary oncology person is generally the person that I'm going to talk to and speak with, because it's not usually the person that's in the hospital every day, so I like to update with what their interpretation of what's going on with the patient, because the docs in the hospital are just meeting the patient and kind of getting to know them. So it's good for background. It's also good for when the patient is struggling with decision making and review and deciding what to do and moving forward, to have the oncologist come in sometimes with our meeting and just, say, here's the facts. We call them ACP meetings, but they're really like about a lot of the doctors in the hospital also are not good at giving bad news. Obviously, I mean, they are trained for how many years to treat people and make them better. And going in to say there's really not much else left to do is something very difficult. So having the oncologist that maybe you have been working with for the last year or couple years, a lot of the oncologists have known their patients for a very long time, and they have a very personal relationship. So it's something that I value, getting to know a lot of them and really having them come in and interact, with us. Really helpful.
Thanks, Marge. You said something that probably just makes a lot of sense to you, but I'm going to guess doesn't necessarily make sense to me and maybe other patients, because I think you were talking about sort of hospitalists versus, so, I have this image in my head that, if I was in the hospital, my oncologist is going to be running over every day to see me and checking in, and she's the familiar face to me. I think at large university, like large hospitals like University of Pennsylvania, maybe different than community hospital setting, it doesn't necessarily work that way. So
Right.
I think you were making that distinction.
Exactly. It's like, and we also see folks whose oncologists may be even out of state, because we see a lot of folks from New Jersey and Delaware and other places. So even just getting those oncologists on the phone, and having some conversation with them is great, and making them part of the decision-making process. Very helpful.
Thanks.
Yeah.
So interacting with the patient's primary medical team, Katerina, would you like to chime in here?
Sure. We often get referrals, consult requests from our oncologists, especially and as in the course of the disease, when there's something new and unfavorable. that they've just shared with the patients. They will often, put in a consult to have the chaplain come and help the patient process it. So we interact very naturally, very regularly as part of the care team. Spiritual care providers are on the care team. We document in the patient's chart. Oh, and I don't want to forget to say that chaplain services are not charged. So I don't want to say they're free because they're not free, but you're not charged for chaplain services. So if you're ever in need of a service, of a spiritual care provider, please don't ever hesitate to call. Okay. So yes.
Yeah. Because many of us feel like we walk into the doors and the meter starts running on everything that we're doing. So thanks.
Yeah, Glenn, I see a question in the chat.
Yeah, and I came in and I want to come to that. Danica, did you want to add anything about interacting with the medical team, or can we take the question from the chat?
You can take the question because I don't really interact with the team in that way in the setting of when I do my work.
All right.
Yeah.
Thank you. All right, we have a question from Valerie Jazowski. I hope I pronounced that correctly. She asked our panelists to respond to what things we can do as patients to prepare our families, I guess, for this moment. So thanks, Valerie, for that question. And I'm going to start with Danica, since we ended with you. And
hi.
Did you get the question?
Yes. One of the things that comes up for me often is legacy work. So maybe there's letter writing. Oh, wait, this is for the families, to prepare the families?
Prepare
is it for
the
patient
families.
or the families? Oh, to prepare the families.
Yeah, what things would you advise a patient? We have a lot of patients, I assume primarily patients on the webinar today. What could they be doing to prepare their families for a moment that may come?
I think some of it we've touched on already is just starting the conversation around what's really happening, seeing where they are in terms of, because oftentimes the person that may be actively dying is in a different place than the family. For instance, sometimes I've seen there's a lot of resistance when the client, the patient is ready, has decided to go, the family wants them to keep fighting. So I would say try to have as you can, and then I guess to have open communication. And I know that's not easy. I don't say that in a flippant way. And if you can't have those conversations, try to get support so that you can. And to just start having the conversations around all of it, around what your wishes are, what would they like to contribute, maybe, because sometimes there's things that the family would like to do for the person, and maybe they don't want to say, or maybe they're embarrassed, or whatever it is. So I would just say start talking and connecting with each other and letting them know, I guess, that each, like, whenever, if I found sometimes if the family's not okay, the person that's passing away is kind of tends to hold on. So that sort of tending to the relationships and making sure that everybody is an okay place as they can be.
And am I pulling out something that you said, is that if you feel as the patient that you've come to this moment or it's near, share that with your family, right? Because I can imagine, you may be seeing your doctor. Your family might be along for that moment as you think they might be. And maybe that's the open communication that you start having with them, because if you're at where that moment's coming up, you don't want to, be at the very last part of that moment, so to speak, and then start to have those conversations. I guess it would be right.
Yeah, even for instance, I was seeing someone every day leading up to the time that he died, and he would tell me he was afraid, but he would never tell the family that he was afraid. So then I would, then one of the family members would say, well, what did he talk about today? And it was upsetting because they felt, why doesn't he tell me? So I think being able to support everybody, because there's no right or wrong in that. And I think helping support, I don't know if I'm answering this right. I'm going to stick to what I said earlier. In preparing your family, just being as open and honest as you can with what you're feeling, where you're at, what you're thinking, and what you would like to see the rest of your days look like.
Right.
So that I think one thing that families sometimes miss out on is contributing in a way that feels meaningful, because they just don't know.
Right.
And so, yeah,
So
I'm gonna stick with that.
Again, take an open is as the headline from that. Marge?
I think I agree with a lot of what Danica just said, but I think the most important thing is to be as honest and open with everybody in your family as you can. Sometimes that's not so easy, though. I just had a patient this week, actually, who was having a difficult relationship with mom. Mom had her own things, though. I mean, sometimes there's a lot of things that you don't realize are going on. Mom was just trying to be very supportive and hold on to her daughter. It's difficult to lose your children, she's young, and she's second daughter that mom is losing and didn't want to let her go. And so patient was having trouble talking to mom or actually letting her know. Mom wasn't hearing it. She didn't want to hear it, very closed. So we agreed that in the meeting, I would stand at the end of the bed, and I asked her to, whenever that question came to her, talking to mom, she would look at me directly, and so that mom could hear it, but didn't have to really participate if she didn't want to. Very effective and was good, but I think they actually probably talked a lot more after that meeting than they had previously, and you just kind of reading the room. I think that comes with nursing a lot,
Right.
You can step in and kind of see those things, feel those things.
Well, thanks for acknowledging, those that open stance can be really difficult, and what a great creative approach to that situation with your patient. Katerina, and I know there's another question in the chat, which we have time to get to. But Katerina, would you want to add anything to that response?
Yeah, I think, Valerie, that's a very, very good question and a very brave question. I think communication is key, right? Talking to people, but then being prepared to tolerate people's feelings, or loved ones' feelings as they come up, and to understand that their feelings are an expression of love and fear of what's to be. And one of the things that neurobiology has taught us recently, and is that, and it's interesting that it's something the ancients have known, that when we love somebody, they truly are a part of us. And neurobiology tells us that when someone dies, our brain has to rewire, really technically has to rewire, and that is extremely painful. So when we get these powerful responses, It's physiological as much as emotional and spiritual and so on. So I feel that when we see the human being in all of that complexity, we can take it out of sort of the individual and see it and see the profound impact that losing a loved one or even thinking about losing a loved one has on us. So to be ready for that kind of emotion and to be there for the person and to simply tolerate it, let it be. And Margie, I'm gonna take that technique and try it sometimes. That really is brilliant. It's a way to give people a chance. And Valerie, it's also great, engaging ritual, right? To convey a message that's kind of otherwise not tolerable. Having a go-between, have someone else talk to the person, that sort of thing. But it's a very important matter. Thank you for asking.
And Katerina, you're bringing up, I mean, I think in the beginning of answering this question, we're thinking about the patient helping, maybe preparing the family. I guess there's multiple sides to this, to what my needs might be, but also understanding what the family's needs might be is equally probably important. And maybe that's how you get sort of a sense of calmness and strength from that, to be multifaceted and thinking about that.
Yeah. Well said, Glenn. Very well said.
So there's a question in the chat. Thank you. And it's from Wexla. And that individual is asking, and I'll let our experts take this one. Is there a particular order to things in terms of, we have a death doula on the call, we have a hospice a nurse on the call, we have a chaplain on the call. Is there a sequence to it, or is it all mashed up a little bit? So if you were going to give some advice to someone, would you have a sequence to what you tell them to do, or does it all sort of come out like soup? Marge?
I do think it's part of that whole planning piece.
Okay.
And it really depends on the individual. I mean, I've been in rooms where patients just want to speak to me first and then have us, speak to the family together, or vice versa, and but I've also been in rooms where I've had a doula and I've had a social worker and I've had a chaplain all in the same room at the same time, because that's what the patient wanted, and the family was good with it. And, questions were just like running all over the place, in the room. And it's really kind of wonderful. So yeah, either way, it really is. That's a very individual question. I like the question. No, it's good. There is no, you have to see hospice first or second, it's up to you. I always like to say the patient is the one who decides. It's always your choice. When, what, where.
And so, Marge, I think what you're saying is you would never be in a room with the patient and say, sorry, you've called me too soon.
No.
You should have jumped. You should have done step one first for the chaplain before you talk to me. So
no, it's all about whatever you need the moment you need it.
All right. Similar answers. I see shaking heads from Katerina and Danica. True. Good. All right. Oh,
I do have a short comment for Vexva. If you're someone who needs an order of things, it's a great idea to talk it over with someone, a medical professional, because it might well be that you need to have your physical care taken care of and your symptoms managed and so on before you can go and move on to more existential issues or emotional issues and so on. But someone on your medical team can help you with that process and help you get to what's best for you.
Good
Good,
advice.
good point, Katerina. Not unlike, if you, before you're going to be having day one care, you need something for pain. The same thing for, existential pain. You may need little Xanax or something, take the edge off before you talk to this group. Yeah, great.
Thanks. And Wexfa, if we didn't do a good job answering your question, you can either chime in now or put it in the chat box that you need us to do things over again.
Well, can I speak? Can I just?
Sure, absolutely.
Yeah, I can't raise my hand. I have stage 4 kidney cancer, but I might be around a while. But we just put my mother up into hospice because she has something. She has basal cell. She's a mess, and so now I know more about hospice than I ever thought I would. And my daughter happens to be a palliative care social worker for senior citizens, so she's an enormous resource. But we never talked much about the doulas. My mother also has Alzheimer's, so we're limited in what she could cognitively participate in. But so I know with my mother, managing her symptoms is primary. Because so that's what happens with hospice. That's the key. When you're at the end of life and it's comfort and you're stopping treatment. So someone in my mother's situation, it's going to be different than my own. So that's why it's a question. I definitely don't want to be in pain. I'm not a hero. But like, where would I start? Like a doula would help me spiritually, but I also would want hospice to help me physically, because if you're in pain, you're not receptive to much of anything. And how long do you wait? And what a yuck. Yuck is my question, is my response. And I bet you this is a typical question for people, because this is such an unusual, not commonplace thing that anybody deals with.
Does anyone? So if I could maybe just repeat that question again, if I heard the question in there, was Wexford, I'm certainly sorry to hear about your mother's situation on top of your own situation. Is when you're unsure what to do, so you haven't pursued a death doula or a chaplain or hospice. Is there sort of a logical first step to take?
Well, I guess, would you consult a doula if you're going to continue on treatment, which is something I would probably not do because I don't see the point if it's just going to, if it's not going to be beneficial. So I would not want to do that. So I suppose let's a scenario where you would say, I'm not going to continue with treatment. So I would want my pain managed, certainly, and I understand with hospice they don't treat, so nothing would be life sustaining. So at that point, is it you get hospice a doula? It's overwhelming to me. That's all I think.
Danica?
Hi, Lexa. It sounds like you have a lot on your plate. And sometimes when there's too much, it's hard to see clearly, and it's hard to make decisions in that position. So I think going back to what Katerina was saying is someone on your medical team can connect you with either a social worker or someone that can help you. I know there's elder care consultants, people that can kind of give you all the options and give you a plan. In terms of what I do, I don't only care for people at end of life. I know it's confusing because of the name, but I have I've been working with someone for a year before they pass. Right now, I see someone with dementia. I don't think that they're close to death in any way. It's just that their health is declining. Mental health is declining, and so I hope that's helpful in regards to my type of services are available as early as you would want them. And yeah, I just wanted to make that clear.
Thank you.
And I hope,
That's it.
and I hope that you get the support you need.
Thank you.
Absolutely.
Thank you.
Wexfa, and it sounds also, I think what we heard earlier was thinking about what your needs are, and maybe come at it from a need perspective, and then talking to your medical team rather than getting hung up on, is this a death doula need or a chaplain need or a hospice need? Just think about it outside of that and just say, here's what my needs are. Talk to your medical team, and they might be able, because they're going to have a lot more experience at it than you, and they might be able to help formulate that plan. They won't be able to think about your needs, and only you can think about those. But if you think about that, and, away from titles and job responsibilities, they might be able to help you kind of craft a plan that would help the situation.
Thank
Fair,
you.
experts.
Fair. Yeah, no.
Thanks, Wexfa, and good luck to your
Thank
situation.
you. Thank you.
Thanks. Anyone else want to jump in with the questions? Because I still have more questions, but I want to give our audience a chance. Okay. When we come back, if someone thinks of something. So let me ask our panelists. You all represent sort of, and this kind of relates actually to something to Wexfa just asked, is that you represent different, but not all kind of communities that, I hate to say this word, but death care workers, people that are working with people who are dying. But you're only 3 people. And who else might care for people at that stage? You've already mentioned, and I don't have them here on the panel. I'm doing this a little bit for selfish reasons, because maybe these are going to be my next panelists. Social workers, you mentioned social workers might be part of the team. And maybe some person could just take a moment to explain what a social worker does in that situation. And then who else are we forgetting in that process? Danica?
I was thinking of, I definitely had social worker on my list, a therapist for mental well-being, elder care consultants, which are people that help you come up with these types of plans. I think it's a fairly new thing, but it is something I'm hearing about in circles. And because I'm biased, because I am a body worker, but I think body workers, massage, Reiki, acupuncture, things that are not non-invasive, that that there's no concern of contraindications or harming someone. I think touch is really important. I mean, always, but especially in those moments, I think it can be really, really, really helpful.
Thanks. And your thought about a therapist, and while I wouldn't necessarily say a palliative care doctor replaces a therapist, I have had discussions with my palliative care doctor that if one was an outsider and put a camera on those sessions, might think that sounds like talk therapy. It sounds like they're doing talk therapy in those sessions. And I think that's okay. I mean, she's assured me that's okay to have those discussions. And because many of us probably are not having those with our oncologists, because those appointments tend to be fast. You're well aware of how many people are in the waiting room waiting to talk to that oncologist. And the palliative care doctor's appointments are, I would say, a little bit more, by design, I believe, a little bit more leisurely. And so we were able to talk about some of those things. So that also maybe belongs on your list somewhere as well. Thanks. Who else? So we talked about Danica, social worker, therapist, elder care consultant, body worker, and maybe a palliative care doctor. Marge, who would you like to add to that?
I'd like to add, we have bereavement services. So our bereavement folks come in all different sizes and shapes, and some of them do adults, some of them do children. And we also have bereavement, pre-bereavement, meaning before someone reaches end of life, they may want to be able to talk to their children and they don't know how, and our child bereavement folks are fabulous and wonderful, and they, will talk to the children directly and FaceTime them and do all those crazy things that kids do today and talk to them in any way they can. And they're really wonderful resources, which are available as well for the entire family, after a patient passes or before. So it's a great group. And I always, like to shout out to social workers, because I think for Wexford, that probably is the first step to go to. Social workers can really help you with planning what's next steps and what you might need. They know essentially everything about, for me, insurance and all of those questions you might have that are kind of technical. And then also they're very, very good with being answering all the social questions.
Right. Yeah, my sense social workers have a much broader command. Like their knowledge base is often like this, sometimes more than like this, and that it's really valuable. Catherine, is anyone you want to have on that, add to that list?
It's interesting, and this is going to sound so off the wall, but everybody who walks into that room or has contact with the person, it really is participating in their end of life process in those final moments, including the cleaning staff, right? I've seen wonderful, beautiful, loving bonds created between the cleaning person and the person in the bed. I'm thinking of a gentleman specifically, and this young man who would come in and pick up his trash, and they would talk, and the old guy found he was in a way mentoring the young man about his life choices and so on. And I'll tell you what that young man did for him. I could have never done, or social, or no one else could have. But this is the beauty of allowing your heart to open and allowing yourself to be loved and to love who's in front of you. So other than that, technically speaking, everyone I know has been mentioned. I just wanted to bring that in.
So unexpected things, and that the person comes in the room doesn't have a title, it's not a chaplain, but probably provides spiritual advice and all kinds of things. So that's a great point. Thanks. Anyone else before I go on? All right. I'm gonna finish up with 2 questions here. The topic here is medical aid in dying. So I don't know whether it's on my mind a lot. There are 9 states in the District of Columbia that have medical aid in dying laws, for lack of a better term, including New Jersey, which is adjacent to Pennsylvania. So I don't know whether that's a topic that you encounter, or the fact that you're in Pennsylvania, you have to not encounter it. I don't know how it works. So does anyone of our panelists want to jump in with any thoughts about medical aid in dying? And if a patient or a family member comes to you and says, I'm interested in that, how do you respond to that situation? Anyone? Marge? And I'm using maybe a term that isn't familiar with everyone about medical aid and dying. So I think that's
Right.
To me, it seems like a more recent term to do, but it's right to die. You may have, that's probably an earlier term that was used. So
Right.
that's what I'm speaking of here.
Assisted suicide, those
There you
kind
go.
of
That's
things.
good. That's a better description.
But I would, yeah, generally, I do get that question fairly often, and particularly if somebody is quite close to end of life. Many times they'll ask, could we just be done all of this, and could you just give me some morphine, kind of thing. And yeah, I mean, my discussion generally is this is the wrong state for euthanasia, and we don't provide that, but we will provide you as much comfort as we can along the way. But yeah, it's generally answering those questions about what it is, where it is, how it looks, and that it's not in Pennsylvania does make people unhappy sometimes. Yes.
Right.
There is a group, though, I think, working on that in Pennsylvania
I'm
state.
sure that there's a lot of groups working on that across many states.
Yes.
Katarina, do you encounter that discussion?
We do. As a chaplain, I've encountered it because people want to know sort of the spiritual implications of that, right? There's no spiritual tradition out there that supports one ending one's own life, right? And so I bring that to say, okay, this is not supported. But let's put it that way. That is certainly never the first thing we talk about. When I hear that, I hear it as a really desperate cry, right? Someone probably who has intractable pain and just tremendous suffering, and they don't want to suffer anymore, right? So it's gut wrenching. It's just gut wrenching. And what we do then is really double down on the support. And body work is so important, Danica. And the human touch, So to sit with someone and hold their hands, that and acknowledge the suffering that they're experiencing in the moment, and to honor that desire not to suffer anymore, right? It really is a profound moment, I think, that profound time that's sort of outside of time and space as we know it, right? That there is something really existentially powerful that happens. I've not been with anyone who's taken that option. I know people who have, and it so goes against our human grain, right? As the witness to that.
Mm-hmm.
But we do get those questions, right?
Danica, do you have anything to add? You don't have to. Oh, okay. I'm gonna end with the last question here from me, which is you all have been in touch with the caring and the spiritual aspects of death and dying. If you can think back on the experiences that you've had, which have been many, and I thank you for bringing them here tonight to our panel, because I think that has been wonderful and wonderfully received by our audience. Could you share a moment that stands out in its beauty? We talked about death not being awful. Have you witnessed a really beautiful moment, something that brought a really surprising amount of pleasure to a patient or their family or loved one that could you share with our audience before we wrap up? Marge?
Yeah, got it. So I have just one from our inpatient unit, which I found really wonderful piece. Patient came in, he was totally knew where he was at. He was end stage COPD, had a lot of respiratory issues, and so, after talking to him, he had this plan because he spent a lot of weekends with his grandson camping. And so he wanted to just have one more evening with him if that was okay. So what we did was we actually moved him out of his room over to we had a children's room. We put up a tent. We had his grandson come in and a couple of, family. And so they camped out overnight. And then the patient, wanted to go to sleep because he knew it was going to be a difficult exit and with breathing, and that he probably would not be awake enough to talk to anybody after that. But the plan was so wonderful, and they had such a good time. And, we all participated. And one other one was we had lots of weddings. People tend to get married, at that point. And somebody came and we had a wedding, and the patient had a peg tube, and so he wanted some champagne. So we poured it down the peg tube and called it a day. It was great. It was really fun. We had lots of fun on the inpatient unit in that way, doing some wonderful things and good times.
Thanks. And what a great memory for that grandson to have, rather than all the memories they could have.
No question.
That's a lasting one, which
It was
is
perfect. Yeah.
Danica or Katerina, want to share something? Danica?
Yeah. Marge, when I worked at hospice, I witnessed a wedding. I didn't realize it was a common thing. I just thought it was the most special thing I'd ever seen. So thank you for sharing that. In the question, you said something about a beautiful experience, and I couldn't think of something that was so specific in terms of like joyous, but I just wanted to share about the woman who led me to do this work. I met her, and she was a physician and not the type of person who was interested, or she used the word believed so much in integrative modalities. And I started off just as, doing massage, and she didn't want Reiki because she didn't know what it was. And it'd been, when I met her, she was metastatic but was okay, was doing okay. So this was maybe 8 months. We've been working every other week. I'd go see her. We at first started, she would come see me, and then it was getting to where it was harder for her to get around. So I started seeing her in her home. And the thing that was so profound to me was, and I guess what made me realize that I think to what Katerina says, is like every person, everything is spiritual work, right? If you have an open heart and are loving, it is healing and helpful to people. I saw her soften over time to say, because she would say like, I just need, this hurts and whatever. And I, still not being a believer, not that I was trying to convince her to believe in something, but I'm just like, it's just known, like touch is healing. So if you're getting a massage, you're going to feel better. For some reason, she just wasn't convinced. But so I working with her over the time and seeing the physical changes from her body changing, her whittling away. It was such an honor to see that, to witness that progression, but that she allowed me to see it, and that she would say, this is really helping me. It was just really meaningful to me and beautiful. And yeah, I just think the witnessing of this, being with a person at this time, is just such a, I mean, I don't want it to sound cliche or corny, but it is an honor. I feel really lucky that she showed that to me. So.
And maybe the message there also is that be open to new experiences, because it sounded like she was not so open to this experience, and she became open. And
Yes.
in this case, felt pretty rewarded, and for her to tell you that this was actually a positive and not the negative thing that she thought it was going to be is wonderful. So I think that's probably a message. Also, be open to new experiences, no matter
Absolutely.
where you are in that journey. Thank you. And Katerina, do you want to wrap us up?
Well, this was something I witnessed standing outside the door. A man was very much near the end, and he had been married to an atheist, but they had an agreement that when it came time for him to go, that she would get a priest to anoint him, give him the sacrament. And so I was called, and we knew it was imminent. So I grabbed the priest and I ran with him to make sure we get there in time. But we got there, but then his very disheveled, troubled son showed up, and she didn't expect it. The wife didn't expect it, and she said, "Well, and she's like, well, what can we do?" I said, "Well, his son is here. That's the most important thing. Let's get him in there." And the man was not responsive, and the man and the son had a conversation. I get the chills even now, and it was that I'm sorry, forgive me, I forgive you, I love you, a goodbye thing happened. It just happened, and then he was non-responsive again. So the son came out, and the priest went in and did his thing, and then of course we and then I'm standing there with the wife, and says, "Well, what does one do in these moments?" And I said, "Well, we stand in awe. We stand in the waiting room of heaven, and we stand in awe. There's nothing to say." But that was profound.
Wow.
And kind of mysterious. I don't know how that happened.
Maybe we're not supposed to know. So good. Well, thank you. First of all, a big round of applause for our panelists. They gave up 2 hours of their night to be with us, so we really appreciate that. We touched on so many topics, really a broad range. So thank you very much for that. There are probably a lot of topics that we haven't touched on tonight, so feel free to either send your comments to Judy Nicholson. They can reach me through Judy Nicholson of things you'd like to see us discuss in the future in this series. That would be really helpful, because the series is very much informed by what your needs are. So appreciate that, and I got some ideas too from tonight. So thank you for that. And I know Linda has put a couple comments in the chat as well. This will be available on her Judy Nicholson YouTube channel, I think probably shortly. And with that, I wish everyone sort of a great evening and a great rest of the week. Thanks for being here. Thank you, Danica, Katerina, and Marge.